Great. So thank you all for having me. It's great to be here. And thank you especially for Jeff and Boeing for asking me to come here. So I think if we want to fix healthcare, in the end, it's pretty simple. We have to change how actual people get actual care. In some ways, if you don't change how actual people get actual care, it's all a waste of time. And by the way, there's a lot of waste of time going on, right? And so in the end, we have to change the trajectory of people. We have to improve their health, and we have to keep them out of trouble. Our proposition really is that the right place to start with that is primary care, right? I think it's a great lever point. We can help people with the upstream. We know for a fact that a good part of what determines outcomes has actually nothing to do with medical care. It has to do with how people feel and how they eat and how they exercise and loneliness, and particularly with seniors and employed people, a whole lot of other things which are not medical, and we can actually help coordinate that in primary care. And then even when we do the best primary care, the people end up having to navigate this whole health system, particularly when they're under high deductible plans and HSAs. They need someone to help them spend their money. Thinking that a consumer can make these decisions by themselves is fooling ourselves. These are really hard choices, and there's a lot of dynamics, particularly when you're sick, that you don't want to make this yourself. You need someone trusted to help you do it, and primary care is a great place to do it. The problem is that our current primary care systems are not at all built for this, right? Our health system is built on this transactional model, document, code, bill, next. And the games are all about doing more stuff to people, and that's what all of our health systems, all our IT systems, all of our salary models, all of our processes, everything is built around this transactional thing. Last I checked, transactions have never healed anyone, right? The things that heal people are relationships. And what we've been doing is at Iora Health, I'm a primary care doc. I started this company about 8 years ago. The idea is, what if we build a vision of what care ought to be? And let's stop making excuses why we can't do it. And let's only do it. Let's not try to, I think, unfortunately, a lot of the ACOs that Boeing works with are existing health systems who are largely seeing fee-for-service, turn the crank. And what Boeing asked them to do is, for these subset of your patients who happen to be Boeing members, I want you to treat them differently. And they all say they will. And the honest answer, to be quite honest, is, again, go back to does actual care change for actual people? It's not entirely clear they really can or want to change, right? So we said, what if we start over? What if we build a new system, built on primary care, bottom up, change how people get care, and simply do the right thing? Now, why are payers important? The base of this has to be a different business model, right? If we get paid the same way everyone else gets paid, fee for service, pay per sick visit, perseverate over the 99214 versus 99213, we'll never make progress. Fee for service is the wrong way to pay for this. And there's a period at the end of that sentence. And so what we say, we need payers who are willing to be progressive. So Boeing is one of our first customers about 10 years ago. Now we recently have started working with them again in Mesa, in Arizona, where they give us a fixed amount to take care of the patients. Direct primary care is the moniker that's being used for that. And by the way, we're doubling down on the primary care. Primary care is typically 5% of healthcare spending. That means 95% of what we spend in the US is what I call failure of primary care. That seems like a really stupid investment philosophy. So let's actually double down on the primary care, actually take care of these folks, and we'll see the savings on the back end, right? So need to get paid differently. And I think we've seen the private industry, particularly self-insured employers, they've been able to support this. We serve a number of self-insured employers like Boeing, Dartmouth College employees. We've worked with people like Zappos, unions like the Carpenters Union in Boston, state employees in Massachusetts. And by the way, the people who are driving this are people like Boeing who are large, geographically concentrated, and have long-term workforces, right? Because the dirty little secret of all this is, if you want to do I call what we do high-impact relationship-based care, you don't see the results in 2 months, right? We're building relationships, we're changing behaviors, we're changing biology. That doesn't happen in even a year. We may actually make costs go up the first year. It's exactly the right thing to do. So we need people who are, these patients are going to be their problem for at least 2 or 3 years, and that makes sense. So number one is you have to change the business model. Number two is then you completely redesign a system of care around what we're trying to do. And our job is not see more patients, is not bill higher. Our job is very simple. We have a population of people, we know exactly who they are, and our job is improve their health, keep them out of trouble, and this last piece is key, and do whatever it takes, right? So what does that mean? So now we say we're building big teams around patients, not just about doctors. Right? What I can do as a doc is I diagnose and prescribe. That's the easy part. The hard part for patients. And by the way, the bulk of the problem is chronic disease. That's what we do really poorly in this country. That's what's driving all the costs. And I think the hard part is how do you help patients execute on the plan? So we have these people we call health coaches. They're from the community, speak the language of the people they serve. They're picked for empathy, connecting to another human being, 3 of them per doctor. And their job is help patients understand what they're doing, track what they're doing, hold their hands when that's the right thing to do, kick them in the behind when that's the right thing to do. We integrate mental health into the model, so we have, and we're not doing it because anyone's telling us to do it. We're doing it because it's the right thing to do. It's really simple. If you have to force people to do the right thing, you have to ask if they're the right partners, right? So we say we're going to put it in because it's the right thing to do. Mental health is such a big barrier. Put social work in practices. Interact with people not just by visits, but email and text message and video chat. Reach out to them. Teach them how to eat. Take them to the grocery store. Put them together in groups. Help them navigate the system. Build a de facto narrow network beyond us. It's not a little different. It's completely different. We've had to build a new IT platform. All these electronic health records out there, by the way, are not built for this. They're built to document, code, and bill hire. No surprise, so we've had to build our own. And it really is a very different culture. We're trying to scale this. We're doing this in 24 different practices around the country. We're doing it in 8 different markets. The hard thing about healthcare is it's not like scaling Starbucks, where you can just put the same thing. Starbucks is Starbucks, but I think healthcare is local. So what we do in Mesa, Arizona is actually very different than what we're doing in Seattle, for instance, because they're very different populations and expect different things. And by the way, it works, right? We've had lots of experience. Patients love it. We have net promoter scores in the 90% range, knock it out of the park on quality metrics. And by the way, most of the quality metrics we're tracking are the wrong metrics. So we can do that, but we actually track better ones like self-efficacy and confidence and things that we think actually matter in terms of relationship. And we're driving it on healthcare costs by about 20%, 20%, largely based on big drops in hospitalizations. So why is this not getting bigger? Why are not more people doing it? I think really 2 big reasons. One is most payers don't have the guts to do this. And I think Boeing is great that they are willing to actually catalyze this. And by the way, if it's not clear, we're a new entrant, right? So I think thinking that we can solve healthcare by only working with the current people who are making a ton of money off the system is fooling ourselves, right? No industry has changed because the incumbents just woke up and decided to be better. We can change by people like us, new entrants coming in and challenging the status quo a bit. We're not making money off of filling hospital beds. So I think having payers with the guts to actually catalyze new entrants, that's key. By the way, CMS, in its wisdom, is not able to do this. Despite all the rhetoric about APM's advanced payment models, every one of their advanced payment models are built on a fee-for-service chassis. They're all fee-for-service with some true-up at the end. If you want to do an advanced payment model, stop the fee-for-service and let us do it. Now, I think they've got an RFI that just came out that seems to indicate they're going in that direction, which we are hugely applauding, right? But I think number one is we need sponsors, payers willing to go out on a limb a bit and try new things. And then number 2 is I think there are a bunch of regulatory barriers out there. The HSA rules that Jeff mentioned are one of the big problems. I think the way we do a lot of regulation, a lot of the Medicare regulations, I think as Secretary Azar said, are built for an old world, and we need to update them to allow us to be able to navigate patients through the system better. Meaningful use, I think some of the NCQA regs are all, again, built for the old system. We need to rethink a lot of them. I think there's a vision of how we do things better. It really works. Patients love it. By the way, docs love it too. And I think having payers like Boeing, who are self-insured, who can break the rules and can encourage it, will actually move things forward. So thank you.
Oh, thank you. Rushika, I've got one question for you. I was thinking about, you mentioned in various parts of the country you have practices that you're working with. To what extent does success require that they be completely in your model, or can your model work alongside their other patients in traditional fee-for-service?
Yeah, so we have made the choice that we will, in our practices, only do this model. I actually think that the sort of care we're doing, this high relationship-based care, it's not a little different than the old system. It's completely different, and that it's impossible to do both in the same place. So again, every other business has figure out what you're good at and do it, and don't try to do other stuff, right? And I think this is really, really hard for existing providers to get over, right? That maybe this is a different model, and maybe we need to do it in a different place. We firmly believe that we need to do it separately.
Yeah, thank you.